Leonard again. I have to apologize on behalf of my co-chair, Sam Piri, who's having some connection issues. So I'm going to stand in for him and moderate the Q&A session. So we've received a couple of questions. Please do feel free to keep on writing in the chat. We will be monitoring as we address the first few questions. So maybe, Leonard, I can start with you with a couple of questions that have come in. And really thanks again for such a topical presentation in a time where we've all been confronted with changing to virtual meetings and workshops. And it's actually really fascinating to see that you've been pioneering some of these ways of collaborating and learning together collaboratively. So we've received a couple of questions for you. What regards the perhaps a question regarding the language barrier, and have you seen that there is less participation in, for example, the Francophone countries in West Africa, but also Mozambique and Angola? And do you think that there might be a language barrier there, or are there perhaps some other reasons for a barrier in participation?
Thank you very much, Anna, and thank you. That's a great question. Obviously, when it started being a model that was studied in the US, which is English-based, most likely the first few countries that implemented this model were English-based. But over the years, other African countries who don't speak English have actually started joining this eco model bandwagon. Looking at the Francophone countries, I know Cote d'Ivoire is running a very good, actually they started the first laboratory eco in Africa. And I know Mozambique is also doing cancer. It's a collaborative with the cancer institution, with South Africa as well. And they're running an eco program there that is in Portuguese. So yes, it's true that initially there was some bias towards English speaking countries, but over the last few years that has changed actually, with more and more African countries that speak Spanish, Portuguese, as well as French also starting to adopt this model.
Thank you, Leonard. I'm pleased to hear that. Having worked in Francophone countries, including in West Africa, it's always a pleasure to hear that. Another question for you, Leonard, and first of all, also to convey, you're receiving compliments in the chat for Namibia also being really leading the high quality distance learning. So kudos to you all. There is a question regarding some of the challenges that you've encountered regarding bandwidth issues and connectivity, and especially in low resource settings or rural environments.
Yeah, that's a good question and a tough one at the same time. Internet bandwidth in Africa remains a challenge, especially in rural settings. Over the last couple of decades, of course, if you compare, there's been a growing number of internet connectivity, looking at the emergence of fiber optics along the way. But of course, there's still challenges in the rural settings. I think one of the ways I can think of in terms of recommendation when you're setting up this eco model is not reinventing the wheel, rather leveraging on what is already existing. In most settings, even though there might be poor internet in terms of 3G or 4G, but there are always other partners or stakeholders that are already in such areas, such as laboratory partners probably already using internet connectivity. Even outside the health ministry, I think that's where we need to start thinking about. Even partners that are outside the health ministries, I'm thinking about banking systems. They use a lot of internet. And if we can find ways to connect and collaborate so that, internet is best utilized so that we can actually gain advantages in terms of this collaborative learning, I think that would be key. Whilst we are waiting for improved connectivity, improved fiber optics along the way.
Thank you, Leonard. And maybe just an additional question that I have is that I've seen, obviously, the ECHO model has been used with a variety of different subjects to CDC looking at outbreaks and the lab community of practice. And I wonder, do you have any tips or, advice coming out on what type of interaction has been able to work best? And I'm really thinking that there's probably your experience is helpful to us all now that we're converting to these virtual fora.
Yeah, that's a nice question, Anna. And I think that's what makes this model unique. People can be as innovative as they can. I was initially biased towards the HIV CAN treatment. I thought the best echo would be an HIV CAN treatment one. But having participated in other echoes and assisted them, I know there is a safe surgery echo that is done by Assist International. And it was something that was mind-blowing. I never thought you could do surgery for echo. But I think the idea is just to know that this is a case-based or a problem-based or an issue-based model where as long as you've got gaps that you want to address in terms of you've got issues that you think a lot of people or the community would benefit from, I think the model would definitely work.
Thanks a lot, Leonard. We have also a few questions for François, but I think François is having trouble connecting. So in the meanwhile, I'll turn over to Kate, who has a question. Kate, over to you.
Yes, thank you, Leonard. That was really exciting, and exciting to see how ECHO turned on a dime to start to address the COVID-19 pandemic in Africa. I wondered about the sustainability of the financing. You said it's financed by PEPFAR, but how much are countries buying into this idea? And if PEPFAR were to withdraw, is there a possibility for ECHO to continue and to be sustained?
That's a $1 million question in terms of sustainability, not only for the ECHO model, but for a lot of HIV programs and, of course, other programs that are being funded. And that's why it's always best to have, right from the start, to have the buy-in of the administrative so that they know that this is something that they're implementing, but this is something that the administrative, the ministries of health will have to take over later on. Speaking of Namibia, I think they're doing that very well. Ever since it was launched in 2015, there's a gradual transitioning to the Ministry of Health actually taking over this program, not only managing and maintaining it, but also expanding it to other facilities. So I think this is about collaboration and, of course, getting the buy-in, especially of the policymakers.
Thank you. We're going to try, I think, Anna-Laura, to see if François can answer with audio only. There's lots of questions for him and the exciting presentation he made.
It is indeed, and I myself, as François was presenting some of the things that I thought I'd understood, I've actually been re-questioning. So thanks in any case, François, for that really thought-provoking presentation. François, can you hear us, and can we try and address a couple of questions? Going to see if maybe in the chat, does anybody maybe from backstage, can people confirm if François can hear me?
He did answer one question. So there was a question that came in about how to counsel our people. Oh, here he is. Okay, François, you can go ahead.
Hi, everyone. Can you hear me clearly?
We can, François.
You're very, very faint, I'm afraid. Let's try audio only. This is not my best look. Right, I apologize for the bad connection. I kept getting kicked off the platform. I did try and answer one of the questions, but are there any others?
So maybe for the benefit of those online, I can just repeat the question, and if you can try and address it. So there was a question around how we can counsel our female patients on issues of weight gain without creating fear and panic, as was the case with NTDs.
It's really hard. It's an excellent question, and it's the frustrating fact that we just don't have answers on this. We don't know whether switching to other regimens will make them stop gaining weight. And you raise an important point. If this was just about men, we probably wouldn't be even having this conversation, because the weight gain in men, it wasn't insignificant, but it wasn't terrible. But amongst women, it was fairly catastrophic. So if it's true that the better regimens are simply a tolerance issue, that the newer, more modern regimens that are just moving us back to a normal trajectory, that's not good news, because we have nothing to offer these people other than the usual, be active and have a good diet, which we know has very limited efficacy. I think we'll have that data over the next 2 years, but I think we need to anticipate that we're going to need some pharmaceutical interventions actually to try and mitigate the weight gain. We're actually looking at studies using tenofovir to see if we can blunt the weight gain. So there's no easy answer at this point.
Thanks, François. Maybe a related question on some of your last comments is whether we have any data, be it in high-income or low-income settings, on weight loss in people living with HIV. So not necessarily linked to dolutegravir, but do we know if there's any data, be it from dietary interventions or maybe some more extreme surgical interventions?
So the only data I've seen is very similar to what we see in HIV negative cohorts. And I think it was really important what the DEXA data said to us is the weight gain, if you can characterize it as normal, it looks like the weight gain we see in HIV negative populations. So it's not like with the thymidine analogs where the weight gain was very aberrant. This looks like almost normal weight gain. And if you're a believer, and I think people like Gary Martins and Andrew Carr are probably erring on that side, that's simply normal weight gain, we can anticipate probably that the interventions, the surgical and bariatric surgery and things like that, diet, exercise, are probably going to have the same efficacy in HIV positive populations as in HIV negative populations, which, as I said, is not good news, because we know that the activity based interventions and the weight and the diet interventions are actually marginally effective, if anything. So I think this is going to be a major research focus for the next few years, is trying to find interventions particularly for women who are gaining weight.
Thanks a lot, François. Many questions still, but we have reached the end of this session. So really my warm thanks again to both Leonard and François for two very different but equally exciting and equally important topics. We now have a tea break, so you can all grab some coffee or tea and take a break from the screen. And then I believe the following session will be a mini oral abstract session. Thank you, everybody.